This is the Evidence-Based Practice Project for Nursing 317. This will be focusing on fall risk prevention. We will be focusing on the role that education plays in reducing fall risk. This presentation was put together by Jacob, Emily, Mackenzie, and Trish.
Statistically, 1/3 of people over the age of 65 fall at least once per year. In hospitals, it is researched that 4.1 to 10 patients per 1,000 patient days fall, but the reality is much likely higher due to falls being underreported. Patients are dealing with more chronic diseases than ever, and patients are being prescribed large numbers of medications that increase their fall risk. Their rate has been decreasing with the use of things such as bed alarms, fall risk signs, and gowns, but the rate is still too high. Nurses can have a huge impact on fall rate when implementing fall prevention techniques for every patient. A quote by the Joint Commission: "Analysis of falls with injury in the Sentinel Event Database reveals the most common contributing factors pertaining to inadequate assessment, communication failures, lack of adherence to protocols and safety practices, inadequate staff orientation, supervision, or staffing levels, or skill mix, deficiencies in the physical environment, and lack of leadership." Fall risk assessment scores should be passed on in a nurse's report if the score determines the patient to be at risk for a fall, so that the risk is communicated and more nurses are aware. Why change is needed? Physical results of falls are physical trauma, deterioration of physical function, exacerbation of chronic illnesses, and impaired rehabilitation. Some data from the Joint Commission. Every year in the United States, hundreds of thousands of patients fall in hospitals, with 30 to 50% resulting in injury that could have been prevented. In addition, 465 reports of falls with injuries since 2009, the majority of these occurring in hospitals. 63% of these falls resulted in death, while the remaining patients sustained injuries. Psychosocial results of falls are lengthened hospital stay, lower likelihood of living at home after the admission, fear of falling, social isolation, anxiety, and depression. Nurses need to be continuing to study new ways to reduce the rate of falls to prevent patient harm. If this problem is not solved, patients will continue to fall at high rates, creating longer hospital stays, increased unnecessary medical costs. The average cost for a fall with injury is about $14,000. Historically, hospitals have tried to reduce falls and to some extent have succeeded, but significant, sustained reduction has proven elusive.
So this is our proposed change. We propose that patient education on the topic of falls risk will reduce the rate of falls. The results will be measured by the rate of falls between groups that received education and the patients who did not receive education will be compared. We hypothesize that patients who receive education related to fall risk will have a lower rate of falling. This is our first article. The first article is called "Elderly Users of Fall Risk Increasing Drugs, Perceptions on Fall Risk and Relation to Their Drug Use." This is a qualitative study. This article is a qualitative study that researches a group of patients who are taking medications that increase their risk for falls. The aim of this study is to evaluate if the participants view their medications as increasing their risk for falls. The participants were all over the age of 65 and living in their own home. They are all taking drugs that would increase their risk for falls. The study found that patients felt their age and their physical impairments contributed more to their fall risk than the medications they were on. The patients stated that no healthcare professionals educated them on how the medications increased their risk for falls. This study brings forward many implications to practice. First, the article exposes that many providers do not provide proper education to their patients on how medications affect their risk for falling. The healthcare professionals must identify medications that increase a patient's risk for falling, and then They must educate their patients on the medication's effect on their ability to ambulate and their risk for falling.
Our second article is called Outcomes of Adding Patient and Family Engagement Education to Fall Prevention Bundled Interventions. This is a quantitative study. As I said before, this article is a quantitative study, but it is researching the effects on fall risk for acute care patients who watch an educational video about fall prevention. The stated purpose of the article is to describe the impact of an educational video intervention for patients and their families added to the current fall prevention bundled interventions at a Midwest suburban 92-bed acute care facility. The population of the study is acute care patients, with the sample being 2,148 acute care patients in a suburban hospital on a medical or surgical or orthopedic unit, with the mean patient age being 66.91 years old. The study took place over 1 calendar year. The results of the study. The average fall rate is evidence-based practice implications. Education before surgery played a significant part in the reduction of falls. Feedback from the staff included the need for whiteboards to assist the communication between interprofessional staff. Showing a fall prevention video to staff and patients significantly decreases the rates of falls.
Our third article is called Experiences of General Practitioners, Home Care Nurses, Physiotherapists, and Seniors Involved in a Multidisciplinary Home-Based Fall Prevention Program, which is a mixed method study. The purpose of the study was to investigate the pros and cons of evidence-based fall prevention programs among seniors, general practitioners, home care nurses, and physiotherapists to create an implementation for fall prevention strategies. The 4 target groups included seniors ages 65 and over, general practitioners, home care nurses, and physiotherapists that were currently involved in fall prevention programs. Because this was a mixed method study, both qualitative and quantitative measures were used. For quantitative purposes, surveys were mailed to seniors, those ages 65 and over, which asked questions regarding their knowledge of fall prevention programs. 74 seniors participated in this study. For qualitative purposes, semi-structured phone interviews were held with these healthcare professionals, trying to determine how they felt regarding current fall prevention programs. The results of this study concluded that the healthcare professionals agreed by saying that they trust fall prevention strategies for the elderly. However, they feel they need to recruit more of the elderly population to therapies both during and after their hospital stay. For the seniors who participated in this study, results show there is a knowledge gap regarding fall prevention programs. Seniors are interested in these programs and should be better informed for fall risk safety and therapies.
The IV, or what we plan to change in the study, is education on fall prevention upon admission. This education would be provided to older adults in an attempt to limit falls in the acute care setting. This will change how the level of education impacts the number of falls and response to falls in the specified facility. This education that was not present before will be added as a contribution to admission assessments and requirements. The rates after this education will be compared to previous fall rates and response to falls before this additional education was completed. And then a follow-up assessment will be gathered and completed once the education has been provided to collect the data. How we will implement the change, or the IV, or education that it is to be provided upon admission. A facility will be assessed and observed for a specific length of time for the number of falls and response to falls number of falls being quantitative and the response being qualitative, before the education is provided on admission. Then, education on fall prevention strategies will be provided on admission to all older adults that are admitted to the facility. Once this is completed, the facility will again be assessed and observed for the number of falls and response to falls after the education has been provided. Staff education will also be a necessity to ensure that all members of the interdisciplinary team are on the same page and will be providing the same type of education upon admission and the same type of response to the falls. It will also be necessary to attempt to understand facility, staff, and the admitted older adults' baseline knowledge prior to the implementation of this education. It's important to know where the education lies prior to the implementation of the education. Before the design is implemented, some prior modifications to the facility, staff, and researchers may be necessary to provide for a successful research study. The staff goals, mindset, and education must be up to par. This provides for the same goals for everyone to promote fall prevention within the facility. It's likely that the facility, staff, and residents, as well as researchers, all are hoping to implement fall prevention strategies to ultimately limit and decrease falls. It's important to understand the goals of the study for the staff. It's also important to have knowledge on the education that's to be provided. This promotes uniformity between the staff, research team, and residents. It's also important to have input from the interdisciplinary team, the IDT team, as they might have valuable input on current and future fall prevention strategies that can be utilized in the education portion of the study.
Our research design will be a mixed method study, as it will include both qualitative and quantitative aspects. The research question is, does fall prevention education on admission prevent falls compared to no fall prevention education during a hospital stay? For proposed change, we want to ensure that fall prevention strategies are taught right at the start of a patient's admission in an acute care setting. Resources needed will involve an evaluation of current fall prevention strategies and changing how we teach them to our patients. All nursing staff needs to be in agreement that these prevention measures will be taught right at the beginning of a patient's admission to the floor. Resources will also include the patient's responses to what they learned and if they actually understood it. To implement this change, the nursing staff will be trained on proper fall prevention strategies so that they can go back to teach their new admits. They must document their teaching and proper patient understanding. Measures will be tracked on reported number of falls in patients admitted to the floor after these new measures have been taken, and patient responses to the fall prevention teaching. This evidence-based practice change will be best implemented on a medical surgical unit, because on this unit, most patients are expected to be up and out of bed, meaning most falls can occur on these units. The stakeholders of this study are the facilities and medical surgical units interested in decreasing the amount of their patient falls. Implementing this change begins with management and nursing staff. Through the use of mixed method research, the staff at the bedside can actively participate in different aspects of the research, resulting in less reported patient falls. Tracking the change begins with documentation from nursing staff at the beginning of a patient's admission and patients' understanding of their teachings for what they can expect during their hospital stay. This would include bed alarms, call lights for help frequent nurse or nurse assistant rounding, to just name a few. Evaluation on the fall prevention education will be based on patients reporting and understanding of the information they learned, meaning, is their admission education effective enough to aid in avoiding falls throughout their stay, as well as the number of reported falls in a 3-month period. This would answer the question, is there a decreased number of falls with the new strategy of educating the patient right at the start of their admission for fall prevention?
For a successful change to occur in the facility, an interdisciplinary team must be utilized. Physical therapy, occupational therapy, nursing at all of the different levels, maintenance, and others depending on what the facility encompasses will be utilized for the study. Physical therapy can provide important knowledge on safe transfer goals for each older adult depending on their transfer status upon admission, strength, goals, rehabilitation status, and diagnoses. Occupational therapy can assist in fine motor goals and home and facility modifications if there's a need to modify transferring or ambulating to work with the patient to be successful for them. Certified nursing assistants, or CNAs, can really provide a sound base for understanding how falls really occur at the core. They're on the front lines and working with residents every single day and can provide valuable knowledge onto how falls occur and the true response to these falls. Registered nurses are the ones that are responding to the falls immediately and can provide ways in which the response should be utilized. Maintenance may also be an important asset to the interdisciplinary team, as they can ensure that there are realistic interventions in place per the facility guidelines and state guidelines. Depending on what may be utilized in the facility, it could be foam mats, bed rails, etc., but they will know the guidelines that can be utilized in the facility per state and corporation guidelines.
The first risk of this study is that the interventions will have no effect on the fall rate and the patients will continue to fall. And the other risk of the study is that the interventions will take time, and which will take time away from doing other things. And this is especially damaging if the interventions done have no effect on the fall rate. Possible benefits of the study include a decreased rate of falls, and another possible benefit is the patients will be more educated as to their risk of falls, and they'll be able to prevent falls at home as well as during future admissions. The dependent variable for the study is the rate of falls. The rate of falls will be assessed before and after the intervention, and the intervention will be identified as effective if there is a decrease in the rate of falls after the education has taken place. The setting should adopt the change because falls are a significant issue, and education has been proven through research that it is effective at reducing falls. Also, the benefits to the study greatly outweigh the risks. Looking at the long-term effects of the study, we will identify that the change is working if the fall rate is shown to be lowered through an extended period. It will also be important to see how the change affects different patient populations as the unit cycles through groups of individual patients through time. If the change continues to reduce the rate of falls through the different cycles of patients, it will be shown to be effective. The rate of falls after the patients are given fall-specific education will be monitored in the long term. The length of time this will be monitored will depend on how quickly the unit turns over patients. If the unit averages a lower than usual time of patient stay, there will be a high amount of patient turnover. This will increase the sample of patients we can study. If the length of stay is longer than usual, the population of patients is more stagnant. This will decrease the amount of cases that can be studied. This could also lower fall rates because the patients typically don't fall more than once when they are on a unit. This could also result in an artificial increase in the rates if the patients have to stay longer due to many compounding chronic illnesses. Either way, the study will need to go on longer in order to evaluate more effectively. Essentially, the length of time is very dependent on what unit is chosen for the study.